So thank you so much for sitting in the front. That's very welcoming to our speakers. So thank you so much. So this is the second plenary, and the topic is integrating evidence-based preventive interventions in partnership with diverse communities and systems. So welcome. My name is Aleta Meyer. I'm at the Office of Planning, Research, and Evaluation, which is in the Human Services part of the Department of Health and Human Services, so Administration for Children and Families, and there I'm the lead for Prevention and Resilience. And I was one of the co-chairs for this plenary, and Jacqueline Lloyd from the Office of Disease Prevention in the Office of the Director at NIH is my co-chair. And she would like you to know that you want to write down all of your questions and bring them to the round table afterwards, because we're going to have a great discussion, okay? And then the other folks on the committee were Dionne, Godette-Greer, Cady, Berkel, Jeong, Choi, and Amy Goldstein. And so I just want to say a little bit about the theme. I'm finding myself being very reminiscent to the year 2010, because in the year 2010, the Affordable Care Act was passed. And that was one of the first places where there was evidence-based policy within the legislation. And so the Maternal Infant Early Childhood Home Visiting Program was one of those evidence-based programs within that. And so I was recruited to come to the Administration for Children and Families to help think through the research and evaluation and data requirements for the tribal set-aside. So there was a 3% tribal set-aside. But there also wasn't an evidence base for what worked in Native communities. So it's an interesting position to be in. And I remember when I first got there, I had the privilege of going to New Mexico to visit some of the grantees and talk with them. And I remember saying what was sort of the tagline at the time, that, right, these programs aren't evidence-based for you, but just implement them with fidelity the first time. And after you've done that, then make adjustments. They're like, what? And I said, yeah, do it with fidelity, and then you'll know what you need to change. And it didn't make any sense what I was saying. And now I know why it doesn't make any sense. And I'm so excited to have these presenters who are going to be telling you a different story about partnership when you are doing that implementation. And so Dr. Shoba Ramanadhan from the Harvard, the School of Public Health there, she's Associate Professor of Social and Behavioral Science there. She focuses on strengthening systems to advance prevention of cancer and brings together the fields of implementation science and community-based participatory research. And she's going to give us a little bit of background on that, but we know everybody knows all about that, but just a little bit. And then Rosalind Bello, who is at the University of Texas, I always want to say Maryland. University of Texas MD Anderson Cancer Center. She is going to be talking about the implementation system that she leads in support of different preventive and cancer prevention efforts. And then Dr. Karina Walters, who is the director of the Tribal Health Research Office at the National Institutes of Health, is going to be sharing about a really co-creative process of partnering around evidence-based interventions for prevention. So without further ado, I will pass it on to Shoba.
Thank you all very much. It's wonderful to be here with all of you in this great group. So I'm Shoba Ramanadhan, and I'm looking forward to sharing with you a little bit about what partners and I have been finding in terms of what works and what is challenging when we're trying to integrate evidence-based interventions into community-based organizations. Is this extremely loud? No. Okay, it sounds like it to me. As I get going, I just wanted to start by acknowledging the many partners whose work you will see here today. All of this exists because we all do it together. And as was just said by Aleta, we wanted to do a little bit of grounding about, what implementation science is, what participatory research is. Looking at the posters yesterday and hearing the conversations today, it sounds like there's an incredible amount of expertise in this room, but we wanted everybody to sort of be on the same starting page. So we often think about implementation science as, sort of this evidence generation continuum, right? So we do our efficacy work and see if our preventive intervention works. Once we have evidence that it does, we move it out into the world, but still fairly tightly controlled settings. We get our effectiveness data. and then magically we're able to spread it to everywhere that needs it in our implementation work. And clearly it doesn't work that well. I think the COVID-19 vaccine was an excellent example of where we had that effectiveness data quite early and quite quickly, and yet we're not able to deploy this necessary intervention equitably and broadly, and in the timeline that we needed to do that. So, clearly we've been talking in the last, I would say, decade and more about thinking about implementation much earlier. So when we're in that efficacy stage, making sure there's a home for this. And if there's not, starting to create one, right? So that there are implementers, there are people who are willing to pay for it, people who are willing to put this on their political agenda, all of that good stuff. And I came to this work when I was doing some program evaluation at the YMCA in an after-school program that was charged with running an evidence-based physical activity program. And so this is 2006. I was in my doctoral program. I took the job because it paid really well, and I was interested in physical activity. But what I found when I got there, for this evaluation program, was that what I was seeing on paper in terms of what was supposed to be happening in practice versus what I was actually seeing in the after-school settings were completely night and day. And that's not news to anybody in the room, but I think what was surprising to me was that the program was asking these high school students, early college students, to run a pretty complex intervention without a whole lot of training, and definitely without a grounding in public health, without a grounding in program implementation. And also for those of you who work in community organizations, there's a tremendous amount of staff turnover, right? So we constantly had new people coming in, again, charged with getting used to a new organization and running this complex program. So that was a lot of the challenge we saw. At the same time, we saw that staff were teaching each other, getting each other up to speed, creating interesting workarounds, doing all of this great work to get that program delivered and get services to the kids that they served. And so for the last 18 years, I've been, sort of at that intersection of how can we as researchers do a better job of providing support to implementers, specifically in community-based organizations, and at the same time, how do we do a better job of leveraging and celebrating the rich expertise that sits in those settings when we're thinking about evidence-based programming. So this is one of the implementation science frameworks that I rely on, and if those of you in the room are implementation scientists or know them, there's nobody who likes theories, models, and frameworks as much as implementation scientists do. There are like 7,000 of these. I like this one for social service agencies. There's a wonderful website at the bottom, EPIS framework, that can give you, insight into it. But I mainly show this just to say this is a really complex attempt to get an evidence-based practice program policy through a system, right? And to me, if you look at these, and each of these big domains, and I'm sorry that folks in the back probably can't read this, but these are large domains, each with many, many constructs in it. All of this is dynamic, and all of it is interacting, right? So that's really complicated, and to me, the only possibility to make sense of this is to do this in partnership, right? We're bringing that diverse lenses, diverse expertise, diverse abilities, skills, et cetera, to try to wrangle all of this. And on that note, this is a definition I like about participatory research, really emphasizing the ideas of collaboration, taking an assets focus, which we don't always do that well in public health, asking a question that matters to the community, right? So it's not just our research agenda, it's not where there's funding. Combining knowledge with action, so a publication is nice, but it can't be the end of the day, and then always attending to health inequities. And I also just want to, note that for folks who are newer to participatory research, sometimes folks hear it's sort of CBPR or bust. And I would just like to note that there is a continuum of engagement, right? So we can think about various intentional, strategic, and transparent ways of engaging with a wide range of partners. And so just as one example of the consultative model, colleagues and I are working on a program for young adult sexual minority women looking at tobacco control, and we are partnering with 4 national leaders of LGBTQ health who we could not get to come to monthly CAB meetings and all the other stuff, but we can talk to them every 3 to 6 months or a couple of hours, and what we get in that time in terms of instruction, redirection, connections, grounding in where the field is going is invaluable. And so that's just one example of a way that we can really be working in partnership, but in a way that is appropriately burdened for folks who have that sort of high-level view. Then we can think about collaborative models where it's more deeply engaged, but researchers are still driving the bus. a collegial model, which is more of that sort of CBPR model, where there's real power sharing, joint direction, and then finally these practice-led models. And so I offer an example from folks at Montana State University, where they had an environmental justice intervention that was developed through a CBPR project housed in the university, and then over time, members of the Crow Nation for whom this intervention was developed with and by these folks, they said that, having it grounded in the university is not working for us. We all know what university overhead looks like, right? And so they started moving this out into a nonprofit, which continues to be led by and for the people of the Crow Nation as the distributors of this evidence-based intervention that continues to generate new evidence, right? So I think that's a really nice model of thinking about where the researchers can really play a supporting role, be useful where we can, and get out of the way. So colleagues and I tried to put some of this together with the implementation science and all the ways that we can bring participatory approaches together in a piece in the annual reviews of public health. It just came out a month or two ago. Again, I don't want to go through it as much as to show you how much is happening, right? If we're trying to think about moving an evidence-based intervention, thinking about what strategies we use to get people to integrate it, how we know if we're successful in terms of implementation outcomes, how we know if we're successful in terms of partner-based outcomes. Are we creating long-term systems change? All of this just feels so large that one thing I worry about in the field of implementation science is that then we're getting narrower and narrower to say we want to do this really tight, methodologically sound assessment of whether we can get one evidence-based intervention through one system to achieve a certain set of outcomes. And that is valuable and important, but it then makes us sort of in that position of generating evidence that's not as broadly useful. And that's the whole point of the field, right, is to make things that people can use and sort of achieve the health impact that we're looking to achieve. So that's what I wanted to talk with you about today, just some of the protections that colleagues and I are attempting to put around this work. These are meant to be bumpers. I did not have time for my 13-year-old to do the graphic design work she usually does for me. So imagine it's like the bumpers on a bowling lane or like those cushion things at the trampoline park. And so asking ourselves these questions around who, what, where, when, and how can help us protect the massive investments that researchers, practice partners, community members, policymakers, so many actors are making to advance health equity through integration of evidence-based solutions. So the first one is who. So I think we think a lot about sort of what are the lenses that we can or cannot bring to a given project. So positionality, right? Who am I in this work? What do I know? What can't I know? And to me, that's really tied to team composition. And not like in the sense of, oh, we need to ask those people for some advice, or we need to make sure we talk to them, but real team composition, who is directing the work. And also, why are we called to this work? I have a colleague, Jasmine Graves, who I think will be the president at some point. She always talks about, when she was doing work in carceral settings, asking researchers who were coming in, what calls you to this? Why you? Why this pace? Why these questions? And being able to answer that and in a way that allows us to show up as ourselves as researchers and share what it is that brings us to that work. I think that allows for a different kind of conversation with our partners versus what many of us are trained to do, which is to sort of say that we stand aside from the science, right? So as an example of this in action, colleagues at the Harvard Catalyst, Keryn Emmons, Berkel, and Michael Curry have set up this Community Coalition for Equity in Research. As you can see, it's a group of about 15 to 17 people, and they come with incredible diversity of expertise. So we've got folks from the ACLU, we've got physicians, we've got people who are doing advocacy work, organizing work, working with folks recently released from carceral systems, just an incredible amount of expertise in this group. And researchers are invited to come and present their work, and then they get feedback. Again, from this group, it has this incredible diversity of expertise and is grounded, across the state of Massachusetts to be able to provide some fairly tailored advice. So as an example, somebody was doing hypertension intervention with the DASH diet in Boston for Black Bostonians, and the group said, well, this is great. Why don't you make sure you hire a dietitian from one of the 3 communities that you're serving? That's not rocket science, but it wasn't part of the plan. They said, why don't you recruit in certain areas that aren't on your list, because otherwise you're just exacerbating those inequities in terms of geographical definitions of what areas do or don't get served within the state. within the city. And then they had a great suggestion for grocery delivery. So the folks are going to go to a large multinational corporation that's known for its extractive practices. And they said, don't do that. Go to the local vendor, invest locally, do all of that. And so these are small tweaks that they made. And if you're doing this work all the time, maybe obviously it seems all obvious, but this was all news to the team that came in. And it's also changing the way they're doing the work going forward. Again, this was probably like a total of 5 or 6 hours of investment of folks' time to read the materials that were submitted by researchers. We asked them to submit a video as well. So again, they're saying who I am in this work and how I show up, and then get that feedback. And there's a paper that Keryn Emmons led about this if you'd like to read more. So then on the what, just thinking about, what evidence counts? Whose evidence counts? I think we think a lot about that, right? Whose knowledge is privileged, whose knowledge is excluded. I'll refer you to a piece by Ross Brownson and colleagues. They really just talk about, does everything have to be a randomized controlled trial? Does everything have, does everything have to use large scale quantitative assessments? I think also about this question of whose knowledge, is privileged. Does it have to be done by somebody in a white lab coat? Or can there be a real celebration of knowledge and expertise that sits elsewhere? I keep thinking about what's called golden milk, which maybe you've seen in the grocery stores. It's turmeric, maybe a little honey and milk. And my mom and I crack up because people have been drinking this in India for thousands of years, but now it's a thing at Whole Foods and you can buy it, so it counts. But again, like where all does this expertise lie that we're just wasting, right? And I think that's what calls me to this work, is I hate waste. So thinking about this question of what, the last piece I'll share is on what goals are driving our efforts. So my team and I have been doing some work looking at the different perspectives that practitioners and academics have when it comes to, what do people need in the field to use evidence-based interventions. And when I say practitioners, I'm really talking about community-based organization folks who work to advance health equity. And so we did 17 interviews with folks and found that there was a real difference in perspectives. And these are all people who are quite expert in cancer prevention and addressing cancer inequities. And what the through line was that the academics were saying, we need skills to focus on delivering that evidence-based intervention and to achieve those health outcomes. And of course, context matters, but it's a little bit out of, it's sort of a little bit beyond, what we're doing here, right? We adjust for it, we track it, but it's a little bit separate. Whereas the practitioners really were taking more of a health promotion view and saying, yeah, there's an evidence-based intervention. It exists in this much larger system, which is often a harmful system for our communities. And so we're really thinking about reshaping that as part of this work. So there's a lot of alignment, but really like some pretty different angles that we're all taking on these things. And just to make sure people believed us when we said that, we did this group concept mapping activity, where you have people come together and brainstorm. Again, what are the skills people need to use in evidence-based intervention planning? They sorted and rated them into groups, to create maps, like conceptual maps. And then we analyzed the data for everybody. So this is academics and CBO practitioners. It's a group of 64 people. And then we analyzed the data separately. And I apologize if I'm going in and out. We don't have a screen here. So if we get everybody together, we have about 5 concepts that are showing up. They're the usual suspects, like managing evidence-based intervention implementation, adapting and selecting evidence-based interventions, all that good stuff. But then when we split it out by groups, and we used hierarchical cluster analysis and multidimensional scaling and all this fancy stuff that my colleague Scott Rosas can tell you about, we found that there are actually statistically significantly different underlying maps for this data. And here the through line is really that a lot of the skills that academics were talking about when it came to, say, community, connecting with community, were more in that space of outreach and engagement, whereas practitioners were defining that as partnership. Right? So it's like a different way in which community was engaged. In the same way, thinking about evidence-based interventions and fit, the practice partners were really thinking about this much more in terms of selecting an evidence-based intervention grounded in that context, rather than, for the sort of utility of that intervention and the strength of the evidence, all of that kind of stuff. So what this, sort of just speaks to me is this question of, where can we find alignment in terms of what we're trying to do and what folks are trying to do in practice settings. Okay. For where, we've already sort of, hit on this idea of dynamic, complex context. There's a lot of folks doing some really interesting work with system science and implementation science. Doug Luke is one of those people who writes really beautifully about that. Here I wanted to give you an example from the city of Lawrence, which is about 45 minutes north of Boston. It's about 77% Hispanic or Latino, a lot of folks from Puerto Rico, Dominican Republic, increasingly a presence from Central America, and it's a predominantly low-income community. And I said it was 45 minutes north of Boston. There's a lot of universities in Boston, a lot of researchers in Boston. You can imagine everybody and their brother is knocking on these folks' door, right? And so what they did was they said, enough. We need a process. You all can't come in here and just take our data and run. We never hear from you again. And you're also asking the same questions again and again. And so now there's this thing through the City of Lawrence Mayor's Health Task Force that's the Research Initiative Working Group. And a couple of us who are academics sit on that, but the rest are public health professionals, local government folks, people like that. Again, academics come, present their research and what they want to do in Lawrence, and they get vetted basically. And so one option is people open their Rolodex and say, here are the connections we'd like to facilitate for you. Here's what's already going on. Here's who might have preliminary data that you can either use for your grant or just use so you don't have to ask people the same question again. And then we also require them or prompt them strongly to participate in our dissemination activities, which include a local research fair, engaging our youth, all that kind of stuff. The other option is some gentle guidance and an invitation to return and try again. And there's no gatekeeping. Someone can certainly do research in the city without the stamp of approval, but it's a small place. And that's it. And so finally, the sort of when and how are the last sets of questions I just wanted to share in terms of what we're trying to do to be better in this sort of supporting of integrating evidence-based interventions. Attending to history. So, a lot of the work that we do really starts at that question of like, well, where are we? And how did we get here? What is the why that we're seeing the patterns that we're seeing? Naming them as a group. None of it is new to anyone in the room, but I think naming it and starting at that, a common understanding allows us to think about, well, how do we want to reshape trajectories? The other thing that we really try to do is take desire-centered approaches, right? So really, again, getting away from that deficits perspective, not having to sit in a giant room in a basement and be serious, but to find other ways to do these things. And that joy and that creativity and that sense of community allows us to be creative in a way that we could not otherwise. And then again, just thinking about how do we marry these short and long-term goals. Yes, we have to get the work done. We got to get the research done. We got to get the implementation done. But we also need to be thinking about how those efforts leave the community stronger, leave structures changed, maybe a little bit of tweaks and power imbalances, all that good stuff. Because if we keep doing it, like that's how things change, right? I think there's a lot of writing, to sort of highlight the impact of these small but consistent changes on systems. So I wanted to share one last example. This is from a user-centered design project we recently did. This is again for that project looking at tobacco control among young adult sexual minority women. We had an event, it was a full-day event that to me, used all the principles of community-engaged research. There's just different methods and tools, and it sounds cooler if you say it's user-centered design. But we brought everybody together. We did some community building. We did those kinds of exercises where you can't be wrong, right? Like take a flashlight and tell me 20 things you could do with it. There were a lot of like bridges for ants, weapons for ants. There were a lot of ants. And we got everybody, comfortable and ready to work. Then we did sort of like a brain dump, right? What are all the ways in which evidence-based interventions can't really be integrated into community organizations? And I should say, these are folks who all had 15 people, all had experience with LGBTQ health as service providers, organizers, advocates. 13 out of the 15 identified as LGBTQ. We just had a really wide range of folks in the room and some media folks as well. Again, just kind of tapping different expertise. And we said, well, what's not working with evidence-based interventions? We kind of drew on some big themes there. And then we went into this question, well, what can we do about it? And so we started to prototype ideas. We split people into groups and they got to build out their ideas. They got to present them to each other, build on them, refine them. It's one of those things where there's just like a lot of Play-Doh and fidget spinners and it's just fun. But what it does is it really kind of gets people to think in a totally different frame. And so we had some wild and crazy ideas coming out. We also had a visual note taker who, did this beautiful job of summarizing and synthesizing, but also really made it very clear that what people were sharing with us was extremely valued and was going to be taken somewhere. And so the products we came up with were a process for the people, which is basically sort of like a pull version of implementation science, right? Build a community around a need, find out what's needed, have a modular approach. Like, I don't have to do the thing just because you gave it to me and told me to do it with fidelity. Really being sort of practice-centered. We had an app, because there's always an app. This one focused on mutual aid and redirecting resources, ensuring community members were safe. And then finally, we had something called the Intergalactic Space, which is basically a very nice community center and allowed people to engage in health promotion, but also really focus on intergenerational connections, thinking about, broader goals that they may have for their lives. And in this project, we're not going to build an app and we're not going to build a community center. But what we are going to do is use those underlying values and underlying goals that were shared, right, to really drive whatever is that next step, and really think about it grounding in practice and what does or does not work for folks. So I will stop there. I just wanted to leave you with this idea of, protections we can put around this work so that we don't get into some sort of implementation science as navel-gazing kind of situation, but really are thinking about protecting the investments that so many folks are making when we're in the space of trying to advance health equity. So, thank you.
This one. That one. Okay. I'm trying to get the technology down. Oh, no.
They might have to switch the slides in.
I'm getting the finger to say wait. I would really like to know about those fire ant weapons, because we have lots of fire ants in Texas. That would be very helpful for us. There we go. All right. Good afternoon, everyone. I'm Rosalind Bello, and I'm at MD Anderson Cancer Center and our Cancer Prevention and Control platform. And I'm very happy to be with you this afternoon, and many thanks to SBR for having me today. I wanted to talk a little bit about where my unit sits, because it's important to how we operationalize our work and do it in partnership with our research units in the Division of Cancer Prevention and Population Sciences. And so this slide really illustrates how we work in partnership with Health Disparities Research and Dr. Lorna McNeil, who's the PI on this project and chair of that department. And in the Cancer Prevention and Control platform, I am responsible for our health system strengthening team, for which this project sits underneath. And our Cancer Prevention and Control platform was created to be an institutional resource that really was meant to bridge the gap from what we know works to implementation into the community. We do this through implementing science. We foster multi-sector collaborations. We maintain a focus on sustainability and being able to transfer the projects ultimately to ownership and continuation to community. We ground our work in establishing trust. We strive to build capacity, and we measure impact via our impact evaluation core. The other thing I wanted to highlight here on this slide is that this work could not be done without building first upon the great efforts that have been done by others in this space and building on the relationships that are there, the deep relationships that allow us to easily, even though it takes time, easily go in and find space and hold space with others in the community. So a little bit about THEAL. It's a breast cancer disparities project that's really aiming to reduce the black-white disparities in Houston. If you didn't know, that the women in Houston are presenting at a late-stage diagnosis 20% more than white women. And then there's also about a 30% higher increase in mortality rates. And Houston's one of the only communities that's actually seeing an increase in mortality in breast cancer. So we have two goals that we have, ambitious goals for the project, that in 5 years we'd like to reduce that mortality by 15%, and in 15 years we'd like to do that by 30%. So I mentioned that we do our work through multi-sector collaboratives, in a little bit. You can see around the top there about how we do this work. We also have 3 aims for this project, and they are aligning and developing a shared vision, using data to drive decision-making and reduce disparities, and implementing evidence-based action. But the question of what that data is a little bit fluid. So we're working, we're implementing these things simultaneously, where we are working with our state's all-payer claims database to understand what's happening through a patient journey, and working with hospital systems to understand within their systems what's happening and to map those patient journeys within their systems. But we're also working with community to understand the perceptions and things that are happening there. And we very much consider that to be our data work as well. And that's really what's helping us to inform number 1 and number 3. And I also wanted to just recognize our very generous philanthropic partners that have contributed to funding this initiative. So we've been through so far the community assessment and planning phases of our project, and I'll talk a little bit about how we've engaged community, but I'm going to do it through our building of our structure of the initiative. So this is a structure that we have used for many of our place-based initiatives and our statewide HPV vaccination initiative. And while we are bringing this structure to the table, we rely on these elements and the people contributing to them to drive and select the actions that are moving forward. So the first part of our developing this initiative was really focused on the community engagement, and we approached this through the lens of, can we walk with you? And really recognizing that there are people engaged in this space long before us who have deep relationships that have been doing the work, serving women in communities, through faith-based communities, through health systems. And this really contributed to the development of our backbone team. Our backbone team, even though we are the fiscal home for the funding that is supporting this effort, we really share the role of backbone with other organizations, and I'll share them with you in a minute. And while our project really aligns really closely with the collective impact model, it does deviate some in some areas, but we do hold to the backbone role. And we also compensate our partner members as the backbone committees for their time and their investment, and recognizing and holding that value of the time that they're taking to engage in this space. So we began this in March of 2022 we really just sat around, we had a call, and we just started making a list of who all do we know, what organizations do we know that's doing this work, are there others that we haven't thought about, are there people that might know more than we do that we should reach out to them and figure out who we should talk to. You can imagine in an institution of 26,000 faculty and staff that there's a lot of relationships that are happening across the organization with a lot of these same entities, and so we also needed to do work internally to figure out who else was engaging with these organizations, so we could have alignment so that we weren't overburdening organizations that were already being invested in other ways. And so we narrowed it down to 8 organizations and 13 individuals for key informant interviews. And there were 3 recurrent themes that came up in those conversations. And one is the fear and medical mistrust, access to care, and navigation of the health system. And I think for me, when I really read those quotes, I'm feeling, it's like almost like you can hear the words the people saying in them, is that I'm really feeling like an anxiety and a worry, and not really feeling like there's a place in the health system. So it's like it creates a very visceral sort of feeling. And in all the conversations we've had with people on the ground, their reaction to these questions is also very visceral. So what we resulted in is this backbone committee here, and I really want to take the time to highlight the people here that are doing this wonderful work. Our collaborators at TSU have been on the ground and really leaders in health equity work, and they recently purchased a mammography van and wanted to get more engaged in this space, so they were a national partner for us in this effort. Also, Harris Health System is our county indigent hospital. MD Anderson does provide for certain cancer service lines. We are our faculty practice there, so we have a natural relationship with Harris Health System. And then also the UT School of Public Health. They are the center for the all claims payer database that I mentioned earlier. We have U of H. They are a new medical school, and they have a population health arm that they're building out, and they are reaching into a lot of the communities for which we have wanted to reach, and they've done a tremendous job in such a short amount of time building trust in communities and bringing a variety of providers into communities for home visits and it's community-centered provision of care. And then also we have our Center for Health Communication Partners at UT Austin. A lot of what we heard from our backbone members was around the need for our technical assistance, capacity building assistance around how do we appropriately message, like we know what people are saying, but are we saying the right thing back? And so we're working on a few ways that we can provide one-on-one assistance with them and help them create something that's specifically addressing their needs. And then importantly, we have our convener and senior advisors there. You can imagine in healthcare that's somewhat competitive environment. I say that jokingly because anybody that works in healthcare knows that it can be very competitive. And so you can imagine if MD Anderson came to you and said, oh, we'd like for you to address and look at your patient journey to see where you might be contributing to the, the health disparities of Black women and breast cancer. That might not go over very well. And so we are pleased to have the financial and time support of Dr. Cullen Geiselman, who has a lot of these members on her board and is offered to be our convener to have those conversations. So in this case, it's just knowing who's the right person to initiate the work and help it move forward, and it's not always us. Most of the time it's not. And then last but definitely not least, the women on the bottom, Gilmet Fuller and Crystal Roberson, are our project directors in each of our units that are moving this work forward on a day-to-day basis. So our next point of community engagement has been where we're building out more of that infrastructure for our steering committee, and sort of the overarching themes from this type of engagement has been we want to learn from you and we want to co-create together, and let's figure out what that looks like. And so this has really led to the formation of the steering committee, and this group is the one that's holding us accountable. They are a force to be reckoned with, and I love it. They last week, 2 weeks ago, they listened to our slate of proposals that I'll talk about in a minute, and they did not hold back with their feedback and questions, and they were fabulous. And so we're very pleased to be able to form that. We started that formation with a meeting on June 8th, and these are a few key points that we wanted to communicate to start our day. So it's really about honoring their work and recognizing that there's no precedent for us convening in this way in Houston before, and that we were valuing the work that's already been done, the steps that have been taken before us, and the steps that we're going to take together. And in this process, we did this through guided dialogue, and you could see some of the cross-cutting questions that were there. And there are 4 areas of questions that we wanted to explore, and these are coming from the Backbone Key Informant interviews, and we wanted to hear a little bit more directly from community around what they were seeing and hearing and what they felt like at this time needed to be addressed to get the ball rolling and start to build some collective cohesion around this movement. So the 4 themes that came out of this work were patient navigation, that there needed to be some mechanism to address costs, and then also simplifying the process, and that it was way too complicated and things were all over the place, and a lot of this work had been implemented in silos, and so we were trying to bring more systemness and connection between these organizations doing the work. And then also patient education and provider training as well. So we have ended up today with over 20 steering committee members and still growing. We meet with these organizations monthly. For one large group, there are frequent one-on-one calls as we're getting to prepare for our September 1st implementation phase. And we Meet monthly, we alternate those between virtual meetings and in-person meetings. And these in-person meetings, we always have food. I think if you're in the South, you know the power of convening around food. It's a very, I'll use the word visceral again. You just get to know people more when you're sharing food and you're convening with each other in that space, which I'm very glad, again, that our funding sources allow for that. Not all of them do. And then each of the different organizations can take a turn hosting the meetings if they so choose to do so, so that we're spending time in each of their spaces. So now that we've got the steering committee together, the next step was really like, how do we dig in more around the co-creating, and let's map out this plan together. And so this is really where some of the steering committee members will take a next step and become a formal collaborator, where we will be working with them and putting together service agreements. We don't have grants, we have service agreements where there's a defined scope of work, and they are paid based on how well they meet their milestones and metrics. A function of that really is around our institution and what's the mechanism most appropriate for us to disseminate resources to community. And trust me, this took many hours with our legal team trying to figure out what's the most appropriate mechanism to do that for a state institution. So in order to do that, we issued a request for collaborators, and this is also something else that we use in our place-based work and our HPV vaccination initiative, where we outlined this is the body of work that needs to be done. Would you like to formally work with us in moving this forward and receive some resources in doing so? And the request for collaborators is a little different than your traditional pulling together a proposal and submitting it. We work with them, and we're hand in hand with the organizations the whole way. And the work that the Backbone Committee did and the Steering Committee did is influenced into what were the evidence-based actions and what were the strategies that could be supported through this mechanism, so they could directly see their input into this document. As well as then we're also bringing, I said earlier, we implement science. So we also brought our evidence-based strategies to the table as well, and really tried to marry them together. So the strategic interest form is where this process starts, and we use this form. It is a one-page, super easy. You put your organization down, your name, your contact information. You check boxes of what interventions you think you might want to do. You say if you've got some organizations you think you might partner with, and then we get that information. It's not binding, it's just a place to start the conversation. And we use that in a couple of ways. One, it gives us a sense for who may be interested in doing what, and if we have an opportunity to match and partner people together to foster that collaboration. It also helps us to identify the number and type of subject matter experts that we might need to review the proposals, because they do go out for external review. And then we have one-on-one meetings with them. We're like, great, this is what you said to us. Like, let's talk a little bit more about that. Like, what do you want to do, and how can we support you? And most importantly, during this process, what resources do you feel like you need other than monetary resources to do the work? So again, that work around communication was really, really big, and thankfully we've had a long-standing relationship with the Center for Health Communication, so we're able to build on an additional scope of work for them to provide some technical assistance to these organizations. So once we have that, we go back and forth. We're like, okay, what you say you want to do is aligned for what is we can support through the request for collaborators. Let's have an orientation webinar so that we talk through the entire process with everyone that's interested. We record it. If somebody's not available, they can watch it later. And it's very brief. It just walks through what are the proposal components and how we'll engage with them. And then next we have one-on-one meetings again, where we're really creating and building this with them. We're not sending them off. We're sitting down. What do you want to do? We have a senior health systems improvement specialist on our team. So if they're wanting to do quality improvement, like, let's talk about what that looks like in a clinical setting. We have folks that are wanting to implement some community navigation to resources in faith-based settings. We'll bring in that same staff person to be like, let's map out a workflow. What does that look like? And we work with them on creating these products and processes. And then they get to a point where they then turn in a draft proposal for us to review. And that draft proposal has a work plan, high-level budget at that point. We review it, we meet with them again, we talk about ways that they could improve it, because while we will ultimately have the decision-making around who is awarded, we still need to get it to a place where the external review panel has a clear understanding and feels confident in the projects. And then when the final proposals are due, this is when we present the slate of proposals, high-level summaries, to the steering committee. And this is where I said they really dug in. It was a really entertaining afternoon on TSU's campus. None of the students were there, so it felt like, you know, you're doing something a little naughty, hanging out in a room and getting loud and having a ruckus. But we got a lot of great information from that meeting, and we're able to sort of shift and refine based on what the community said. This is really what we want. This is meeting our needs, or this is not meeting our needs, or we're not comfortable with this aspect of it. And then from there, we sent the proposals out to external review, and that external review is done by our external advisory board, and they use a scoring rubric that is based off the REAIM framework and also the MacArthur 100 and change scoring rubric. Is a hybrid of both, and that really was designed intentionally to be able to determine which proposals have the greatest likelihood of generating impact. And then we sat down last week. We did this twice. We're doing it again Thursday. We'll do it again on Monday. It's a very intensive process. There's a lot of strong feelings about what comes back from the proposal review and what needs to be modified, what doesn't. But we'll hash through all of that in the next couple of days, and then we present the slate of proposals as we see them to our internal review committee. And then we notify the organizations of their awards, and then we go into final negotiations around the scope of work. And then the funding year for this project will begin September 1st. And I think the really important part of this process that I like to think about is that hands-on and working with them is more of a distributive justice issue, where sometimes the organizations that we work with in community are serving those community members that have highest need, but those organizations have high need as well. And if we can work with them to help build their capacity to apply for funding and to understand what does that mean and what are the mechanisms and how do we present feedback in a way that's positive and encouraging, then they can then use those experiences and that capacity to seek other funding, and we frequently assist them in doing that as well. So I think there's anything else to share on this process. It's very lengthy. It takes a very long time, but it's worth it. So just a few things to leave you with here. Time. I just mentioned that process is very lengthy. Also, I mentioned our massive red tape of an institution, of a state institution. And I think it's very important that we clearly communicate what the time horizon is for different things for us. What does that mean when you submit an invoice? What does that mean when you send this to us, but okay, well, we've got to run it up the flagpole 50,000 times? Or what does it mean for us to understand that even though we want something right away, that's just not going to happen because there are competing priorities. So we all have to have an understanding and appreciation for what things look like in our unique environments related to time. Also capacity building, that I think ultimately we go into this thinking how can we build the capacity of communities, but also they're building our capacity. Every time we go into a new initiative or a new project, we're learning more and more for them and tweaking our processes as well. So I think that's a bi-directional effort. And then perspectives is really honoring the perspectives of others, and the perspectives can be data, and that's a really important piece when you're looking at formative data for initiative development and implementation. And trust, that takes a very long time as well. And I think the team members that we have on both of the HDR and platform teams, we each have in this type of work, we each have about 20 people, and I think about half of those are deep in the community all the time, and so we couldn't do this without their continued engagement and trust of community members. And then there is the sticky wicket of contribution and attribution. I think that, I mentioned earlier that we're the holder of the funds. We would prefer if we could just do, like, we have a contribution and not attributing the work to us. Sometimes our branding departments and other things have other ideas about that. And so trying to be very transparent with everyone and finding neutral grounds for how we do that. And we do that through being very transparent and having constant and open communication with our collaborators. And we don't shy away from those conversations, having them at the beginning. And then we also build into our service agreements language around publications and how we would address authorship as well. Because for some of our academic partners, that's a really important aspect, and we address that in the beginning. And I think that's it. Thank you so much.
Halitosa hachifat hatupishe kan transpo chebiche hoyo micha chatasi okay micha yokoke okla pescadaway micha yokoke okla not to chunk and accustomed people. Good afternoon, everybody. My name's Karina Walters. I just introduced myself in Choctaw. I'm an enrolled citizen of the Choctaw Nation of Oklahoma. Now that I have your attention, it's an honor and privilege to be here. I'm the new director of the Tribal Health Research Office at the National Institutes of Health. I've been here for a year, so it's a big transition. But today, I'm going to actually share a little bit about a research project that I had just finished before transitioning into this new role that was actually funded by NIDA. And I think it's really a great case example of not integrating evidence-based, but creating evidence-based from a cultural perspective. So I'm going to talk a little bit about that and how we did that. I first want to just acknowledge Dr. Michelle Johnson-Jennings, my colleague and Choctaw co-conspirator in this project. We both were, I was the PI, she's the MPI. We did this project together. It was a very unusual situation to have an all Choctaw-led team, both at the community base, at the tribal level, as well as at the university-based level. So this was a very unique circumstance, and it's not about they versus them, it's us. It's an us process, and there's different kind of challenges with respect to that, and I'm going to talk a little bit about how this project came to be. But before I do that, I'm going to try to time myself here. I have to set some context. I kind of have to talk about settler colonialism briefly, in 30 seconds or less. I'm going to give you a quick, because it's an important context to understand developing and designing interventions, especially health promotion interventions in our communities. First and foremost, settler colonialism is a structure. It's not an event. It's a system of policies and practices that are embedded in our structures. Manifest Destiny is a good example of some of the philosophies that are behind it as well. But the two things that I want you to take away from understanding settler colonialism in 30 seconds or less, it's about two major things that impact indigenous communities. It's about dispossession of land dispossession, and it's about erasing us from that land so that you can create new narratives to justify continual occupation, dispossession, and free future generations from accountability and disavow violence. There it is, 30 seconds. Settler colonialism, you've got it. But land dispossession, that's an important piece. Sorry. You got 20 minutes. And historically traumatic events are events that are designed to uphold settler colonial structures, okay? And these historically traumatic events are events that target a people, and you can tell this is not just for indigenous people, other populations also, but target a people with four intentions: to commit either genocide, eradicate the people, commit ethnocide, eradicate the culture, life, wage, language, epistemicide, eradicate thought ways, how we narrate and talk about ourselves, right? And ecocide, even eradicate aspects of land that are tied so much to our wellness and well-being. Okay, historical trauma, 10 seconds, there we go. Examples of historically traumatic events, especially I'm going to just use my tribe because I'm going to illustrate a development of a prevention intervention with our tribe. Trail of Tears, y'all heard about Trail of Tears, right? We were the first to be removed on the trail. My tribe, we are all the descendant survivors of those who were removed from the Trail of Tears. That makes up the Choctaw Nation of Oklahoma, okay? It's the 1830s. Land allotment, in the land allotment process was a historically traumatic event for us, and I can go into more detail about that, but again, remember the theme of the land. Land dispossession is tied to our well-being. And tied to that also are blood quantum policies and other kinds of things, so we could talk about that later too. Boarding school is another more contemporary one. If you have an opportunity, read the Washington Post article that came out today about boarding school and the history of boarding school. Deb Holland is doing something right now with respect to, just had the Boarding School Commission report come out, and they're also interviewing and working with boarding school survivors across the country to get the stories told. And at the Tribal Health Research Office at the National Institute of Health, we're in the process of building up towards a boarding school healing summit so that we can begin to develop preventive interventions and also different kinds of interventions for addressing historically traumatic events and intergenerational trauma, particularly around boarding school. Okay. So we do know that there's some research that supports the impact of these kinds of historically traumatic events on well-being. And the three takeaways that I want to leave you with, because this is a foundation for developing prevention and health promotion interventions in Indian country. These events are designed to do three things. I talked about, the different 4 elements of genocide to ecocide, but they're also designed to do 3 major things, which is disrupt a people's ability to fulfill their original instructions as a people, right? So when General Sheridan said, we need to kill the buffalo as a way to eradicate the Lakota people, he wasn't referring just to food sources. He was referring to disrupting their ability to fulfill their original instructions to Buffalo Nation, which is a relative to them. It's a spiritual assault as much as it is a physical assault, okay? So disruption in original instructions. The other one is disrupt our relational ways of being to ourselves, to the land, to our ancestors. When we disrupt those relational ways of being, that's very powerful. The third element is to disrupt how we story our lives, how we narrate our lives, right? If you have land dispossession and you have erasure, you're always having, you've had other people tell you your story. Think about it, right? Think about what you learned about Thanksgiving, what you've learned about Columbus Day. All these things are not our stories, right? They're stories that are purposely told to erase us from that narrative. So we spend a lot of time having to make ourselves visible again, right? And so these 3 elements mean, from a intervention development side, we need to do 3 things. We need to build from our original instructions, right? So our interventions can build from our original teachings. Our teachings provided the guidance for how we live healthfully in the world. So when we can draw from those stories, whether they're children's stories or ancient stories, they're very powerful. So to give you a brief example, I'll give you the comic book version of one from our tribe, and this comes from Dr. Michelle Johnson Jennings' family. Hashkanaya and Hashi shared the sky together. That's the sun and the moon, right? And they were lovers in the sky, and they had their beautiful star children with them up in the sky world. And then it was a day sky all day long. But one day, Hashi, the sun, he gets those sun flares going once in a while. And Hashkanaya, the moon, said to him, if any of those sun flares hit me or any of our children, I'm taking all our star children and we're moving to the other side of the world. Hashi said, no, don't worry, that won't happen. And sure enough, what happened? One day, flare went out, hit Hashkanaya. She gathered all her star children and moved to the other side of the world. Hashi begged for her to come back. He said, we love each other. What are you doing? Let's make this work. And she said, no, this was the rules. And so therefore, but I know we love each other and you do want to see your star children. So once a month, we will gather together and share the morning sky for a couple of hours. That's it. We had domestic violence prevention people in our original teachings, right? If we build from that, we become culturally credible, it's culturally relevant, and it's motivating. We don't need a basic IMB model. We got it right there, right? I don't have time because it's 20 minutes. There's another one called Alligator Power, but if you want to hear it later, I'll tell it to you. And then there's about restoring relational ways of being in the world, right? So if I take action to improve my health right now, in this moment, I'm not only improving the health of myself and the health of my family, I'm actually getting a great opportunity to improve the next 7 generations' health as well. But there's an added bonus. If I take action right now, I'm not only improving the next 7 generations, I'm getting an opportunity to address what I'm carrying in my body from the 7 generations before that didn't get an opportunity to get corrected or healed. It's not a place of disempowerment, which so much of our literature kind of focuses on. It's a place of incredible power. And we start our thinking there, we already start restoring our relational way of being in the world. So that's another added component of intervention development. The third part is we have an obligation to restore our lives back to wellness and well-being. And it's critical that our communities are centering their voices in that process. So I'm going to, that's it. So now we're still here. That's my context and background. So turning to the actual development of Yapali. I had a little bit of a paradigm shift that helped me transition into developing health promotion interventions, because before that I did mostly social epi studies, and I did a lot of my early work on historical trauma and trying to document it and so forth. And I was listening to a Native Hawaiian elder tell a story about crabs in a bucket. You all know about crabs in a bucket, right? And it's used for lateral violence, right? Fishermen were smart. They put crabs in a bucket, and when a crab tries to crawl out, other crabs grab them down. And we've used it as a metaphor for lateral violence and all this. You know, and if I was a social worker crab in that crab bucket, what would I be doing? I'd be like, come on, crabs, let's rise up together. Don't pinch each other, just lift each other up, right? That's what I'd be doing. But he asked a really important question. He said, do crabs live in a bucket? I was like, wait a minute, what? How did we accept this to be crab behavior? How are we living in our buckets as scientists and researchers and community members, practitioners? We've all been sold buckets, and we do learn to live in our buckets, right? That's a little bit of the nature of the systems we work in. But he asked that important question, and then he went on to say, when crabs are in their natural environment, when they are in a healthy environment, you know what they do? They lift each other up on rocks. Now, I'm sure there's 1 or 2 bad crabs in there, I'm sure. That might throw someone off the rock, but the natural crab behavior emerges when the healthful environment is in place. And that was a fundamental shift for me, that I realized I had been looking at historical trauma, I was been doing a lot of this work, really with a little bit too much within my bucket. And I had to bust out of my bucket and started saying, how can we do environmentally based interventions? How can we do interventions that are shifting the environment so healthful behaviors can emerge? And that's a critical factor, I think, for the future directions for a lot of our interventions that we're developing in our communities. And that gets us back to the importance of land. If land dispossession is the hallmark of settler colonialism, and obviously, you know, land is major for our people, right? So any Native community you talk to has a proverb, and it usually goes in translation something like, I am the land is me. But settler thinking is, I own the land is mine. We've got a fundamental difference there. But if I am the land is me, if you are dispossessing the land, if you're harming the land, then the opportunity to heal is back through the land. And a lot of our tribes are talking about this, land-based healing, getting outside of our 4-room walls, our 50-minute sessions, and our service agencies to actually do something that's going to be sustainable. We want sustainable population health change. We don't have time to waste anymore on little tiny increments. We're in a crisis, people. 20 out of 50 of our kids, Choctaw kids, by 2050, 1 out of 3 of our kids are going to be living with type 2 diabetes. And that's what my elder told me. And he asked us, he goes, what can you do about this? He goes, I'm in a generation where our children are going to die before the parents and grandparents. We have to turn this around. My ancestors did not walk the trail of tears for us to be dying the way we're dying. They walked that trail with a vision of love, a vision of life for us, and we have an obligation to reconnect to that vision of love and life and create health promotion interventions with that in mind. And so, turning to our Yapali project, that was the big question. You know, our tribe was doing everything right, and is still doing a lot of things right by Western models. Great stuff. I mean, we've done everything from changing our menus, we've put in walkways, we've done structural interventions, all the way down to great bariatric surgery, behavioral interventions. We have state-of-the-art gyms. I'm just telling you, better than gold gyms. We got great gyms, right? But less than 30% of the people are really using those things, right? And so when they asked us to come forward and try to help with this, you know, I said, well, you guys are doing everything right according to Western models. And they said, well, we obviously need to do something different. We need to be back into our cultural way of thinking, our cultural models again. And so they said, can you help us? And I said, okay, I'm going to walk away. And I didn't say I'm going to go do a lit search because I knew they were doing everything right by the literature search. I actually walked away and said, I'm going to pray about it because I had to come up with something different. And we all had to come up. It was a we process, really. But the answer was simple. It was back to that original question. Our ancestors did not die, did not walk that trail of tears for us to be dying like this. They had that vision of love and life, and we have to recommit to that vision. So we met with the chief sister at the time, who had been doing a lot of work with women's health. And she and I, and then Dr. Michelle Johnson-Jennings, we invited her in. And then we all put our heads together, and Carrie Herod from Choctaw Nation, who was head of health services at the time, behavioral health, we started putting our heads together. And what we proposed was that we needed to create our own Choctaw health promotion model, that we are not going to now adapt another intervention from somebody else. We have to create it from our own people. But how to do that, right? And so what we proposed to do, the how to get to our model, was we decided we would rewalk the trail of tears ourselves. And that we'd bring a group along with us. And that by reconnecting with the land our ancestors walked in, that we would earn the right or the knowledge that would come forward in that process that would guide us in developing a health promotion intervention. Now, I thought our tribe was probably going to think we were totally crazy when we proposed this, because it's, you know, you don't get taught this in school, right? This is coming from a real cultural perspective. But they actually said, okay, let's do it. Let's do it. And then they said, and you know what you could do when you walk the trail of tears? You can think about suicide prevention, and you could think about substance abuse prevention, because we're still thinking of different topics that were important to us. And we said, nope, that's not what we want to do. We don't want to do substance abuse prevention. We want to ask the original instructions question, which is, what are our original teachings around medicines? And if we disrespect them, how do we understand the consequences? And what are our traditional corrective actions for that? Instead of suicide prevention, how do we reconnect to life? And how do we understand living? And if we get out of balance with that, how do we traditionally reassert that balance again? Those were the questions. They're like, oh, okay. Then they said, well, this will be good for developing new programs. We said, no, we're not going to develop services. What we want is to impact change fundamentally at the community level. So who we want to recruit into this project more than anything are the 70% of people who are not coming to services. and mostly our first language speakers, and the folks who don't come in until they're really sick because they don't trust the system, because we want them to be able to produce the change at the community level. And then we decided it wasn't going to be, we did decide it was going to be focused kind of on obesity prevention because of the issue of the diabetes coming up for our young people, but also substance abuse prevention, because those addictions walk together in the brain even. And so we decided we're kind of tackle those two things first, but we weren't going to approach the community that way. Oh, do you want to, be a part of a substance abuse prevention project? Instead, we said we want to build community-based health leaders who will learn how to run their own prevention events, and then they will be there for the community. So if there is a death in our community from a substance abuse overdose, for example, the White Crane women, well, I'm getting ahead of myself now, but the model we developed, all the women from the White Crane Society would come together. Couple $100, and we know how to cook. We'll pull something together. Come together to create a prevention event so that doesn't happen. We don't have a cluster death or a cluster suicide or anything like that. We wanted to build something that was based on our traditions and our cultural practices and roles that were disrupted. So we set out to walk. And it is a form of community-based participatory research. It's an unusual project because we were subjects as much as we were, we were the participants and the research at the same time. We asked people to volunteer, and who volunteered were all women. And we got really worried. We talked to the elders, and the elders said, we said, we need men to be involved. And they said, well, what's happened? And I said, all the women are coming forward. And they said, no. Culturally, that's correct. In ancient times, women were responsible for the ceremonies to return things back to balance. So, so there you go. So we were given permission to go forward with the women because it was, so those stories, when you do something that's really, truly community-based, the stories emerge. The knowledge that you need to have to move forward will be nourished. It'll come out. The community will let you know what you need to know. And it's not a Western approach. Western approach to education or knowledge is we're taught to, you go take it or you go get it. If you don't take it, you're going to get it. From a Native perspective, and I'm generalizing, but I think this is generally true, that knowledge is earned when the time is right. So you can go work for it. You might not still get it, right? You can go fast and you want a vision. You might just have been hungry for 3 days or 4 days, and that's it, because you're not ready for that. So we knew when we entered this that we might not get the knowledge that we needed, but we were putting our trust in our ancestors and our process to go forward with it. Now, the elders said, go do it. You're going to do it in 10 days. We decided to do it in 10 days because if we really walked the Trail of Tears, it would take 6 months to a year if we really did it in our ancestors' footsteps. We decided we were going to literally be in their footsteps. So we did archival research. We looked up old military maps. We did GIS mapping. We were going to be in the doggone footsteps even if it took us through a wildlife refuge, which it did. We also did a ceremony. So we approached this as ceremony as well. And we started with a simple question: what is the Choctaw Road to Health? It was qualitative work. We did journaling, which I would never do. Again, I won't ask anyone to do this. We did journaling. We also had people back home follow us online so they can follow the journey and be part of the journey. We had a few parent-child pairs so we could see how kids did on this, but we couldn't go under the age of 12 for safety reasons. You want to know what our IRB was like? Let me just tell you. You had to be able to survive a water moccasin or a rattlesnake snake bite. So 12 years old was the age by weight and height on average. These are the things we have to think about when you do this kind of research. And we had to find all the different trails, but we also went to the archives and we went to the Smithsonian and we actually held our commutation papers in our hands. And I'm not kidding you, this truly happened and people witnessed it. I opened up the first box that we got laid out on the table. And these are the papers that some of us were required to handle and carry. So when we got to the territory, we'd hand it in. I opened up the box, and I put my hand in, I pulled out, and I pulled my great-great-grandfather's commutation paper. And I brought tears to my eyes, and I thought, would he have thought his great-granddaughter would have been sitting here one day, holding his paper, trying to help our people again? So that really happened. But we did that because we wanted to see the stories that emerged. Like, what were some of the stories? We even looked at the military journals and diaries that some of these guys carried. And you know what? That was healing for us. Because we also saw their struggle, some of them. It actually opened up our hearts a little bit to some healing that needed to happen. We went on the trail. We created an initial preliminary curriculum that we'd open up each day with a blessing and with a guided question. And then we'd walk 8 to 10 miles a day. We were trying to get as many miles as our ancestors did per day. They sent us, the elders sent us to do this in the middle of June. I don't know if you all know what June is like in Mississippi, Arkansas, and Oklahoma. And by the way, Arkansas is incredibly swampy. You don't know it if you walk it like that. It averaged over 100 degrees every day when we did this walk. So I honestly believe that they were putting us through our own trial there. We did digital stories post the walk. And so here's some of the folks that went first on the walk. We had 13 Choctaws who went on the walk. We had 5 Native people who bore witness and were part of the walk and part of the staff that helped us. But also, we wanted to hear their perspectives of what they were experiencing too, to reflect back. Dr. Angela Fernandez has published that, so if you're interested in that. And then we did everything. We actually even had dreams was part of our data. I mean, literally everything was available to us as data. I asked my doctoral students to please not drink alcohol or anything else for at least a month before going on that trail. And everyone was like, what? I said, yes, I need you to be, clear-headed. We're asking for guidance, and I need you to be, your senses to be fully aware. And so they, everyone did who was part of that. We sought proper instructions from our traditional elders and leaders. And here's just some of the highlights, and I'm going to end with that. Some of the parent-child pairs, you see Dr. Michelle Johnson-Jennings, and this is an example of the trail. This is that deep from people's feet actually walking the trail. That's from humans walking. We did this 2 times, and we were not trying to emulate trauma. Our goal through this was always to be connected to the love. This is not about memorializing the trail. It was about reconnecting to a vision of life. And we always kept that in the forefront of our thinking. We discovered the importance of humor and how we realized our ancestors had love and laughter even on the trail, despite the tragedies that happened there. And that was actually an important healing revelation as well, and really realized how much humor is medicine. Some of the things that came out of the initial piloting was we really realized we talk about ancestors as present tense when we're out on the trail. Ancestors are present with us, like right now, in the here and now. Another quote was, when you continue to center the trauma, then you continue to center the colonizer and the colonizing process. That came up. And the other piece was from a young person, said, I heal others when I keep or make myself healthy. That was her revelation. I'm like, done. We're done. Great. Important cultural stories came out on the trail, which I don't have time to get into. But what ended up coming out of this, we did 2 pilot studies. A curriculum came out of that. We ended up getting funded by NIDA. We actually implemented it. Over 150 Choctaw women became health leaders. And the goal was that we'd have a 3-month intervention that starts with our ancient clans guiding us in terms of behavioral change. We start with 3 simple questions, which is, what kind of ancestor did my ancestor envision me to be? What kind of ancestor through my actions today am I envisioning others to be? And what kind of ancestor do I want to really be? So it's always about who are you anchored in relational orientation to your ancestors. We were hoping to create some health societies that would come out of this. So they had 3 months of the behavioral kind of curriculum. It was outdoor, land-based as much as possible when weather permitted. And then after that, we had booster sessions up to a year. And those booster sessions were about event planning primarily. So each community was, each of these women, and they can combine if they wanted to, were given a very small pot of money, $1,000, to plan a community prevention event that will be sustainable, that would continue beyond the intervention. And ideally tied to obesity prevention and substance abuse prevention. And they could tailor it to their local needs. After the 3-month intervention, they went on their own 8-day Trail of Tears walk to vow make to the community that they're, to make a vow to the creator and to their community that they're stepping into this role as a community leader. Then the community feasted them when they came in from walking the trail. And they had a big feast and recognized them for being community leaders. There are interventions that were started 12 years ago, 10 years ago now, that are still going today. Walking Warriors, for example, and others. I can't, because I don't have permission yet, but I can tell you we've run the data, and it's really good. But that's all I can say. It's transformative. We went from 2 cases of soda per day for some of the women to no more water. We went from some younger people in the intervention saying that, younger meaning 18 and over, so that it targeted older 18 and over women, never having had vegetable other than what was like at a fast food restaurant. That blew my mind, because in one generation that changed. My mom always kept a garden. My grandma always kept a garden. I don't keep a garden like I should, so I'm starting to do that though, because in one generation that has changed. Yep, and that's it. So I'm going to close on that and just say thank you for allowing me the opportunity to share a little bit about what we did, and encourage you to build from original instructions, restore relational ways of being, narrative transformation, restore our lives, that is a critical, those are 3 elements of developing health promotion interventions. I don't care what community you're in, I think could be helpful to think about. So, okay, thank you.